So welcome to this presentation on 12-lead ECG technique and the basic interpretation of 12-lead ECGs. So as first responders, paramedics play a crucial role in identifying and treating patients experiencing cardiac events such as myocardial infarctions or other acute coronary syndromes. Now, by performing a 12-lead ECG, paramedics can quickly obtain vital information on the patient's cardiac health, allowing for a faster diagnosis and timely treatment, for example, going to a cath lab or a percutaneous coronary intervention. It's therefore essential that paramedics have a thorough understanding of the technique and interpretation of 12-lead ECGs to ensure the best possible outcomes for patients. So learning objectives for the presentation today will be one, to identify the anatomical landmarks and electrode placement for a standard 12-lead ECG, to describe the process of applying electrodes to the patient's skin for a standard 12-lead ECG, including the correct order of placement and use of skin preparation if necessary, demonstration on how to attach the leads to the electrodes and connect them to the ECG monitoring for a standard 12-lead ECG, and explain the purpose and benefits of using the new electrode placement, or the NEP, which is the non-standard electrode placement method for obtaining a 12-lead ECG. We will demonstrate how to apply electrodes for the NEP method and connect them to the ECG monitor. We will discuss the advantages and limitations of using the standard versus non-standard electrode placement methods. We'll identify potential sources of error or artifacts in the ECG tracing and explain how to troubleshoot and correct them. And then this week in lab, we'll practice on acquiring a 12-lead ECG using different placement methods, again, the NEP or the standard, and we'll evaluate the quality of the resulting ECG tracing, and we'll even start interpreting our 12-lead ECG. So why do we need to do a 12-lead versus a standard 3 or 4-lead ECG? Now I say 3-lead because typically we'll have the 3 leads. We'll have the right arm, left leg. But we've also included a 4th lead, which is our ground lead, just to have a better tracing. Okay, so sometimes 3 and 4 lead can be used interchangeably. 4 lead meaning you have that 4th ground lead, that green lead. But technically you only have 3 vectors. So a 12-lead ECG can provide a lot more important diagnostic information with patients with chest pain or other cardiac symptoms. That's important to note. It's diagnostic, meaning you can actually look at a 12-lead ECG tracing and provide a diagnosis, versus a 4-lead, which has a limited number of leads. So we have a limited number of views of the heart. Well, this, because of limitations, is non-diagnostic. So we can get an idea of the patient's cardiac electrical activity, but we cannot diagnose, for example, a heart attack. So a 12-lead provides a lot more detailed assessment of the heart's electrical activity. And for paramedic paramedics, it's important to be able to identify cardiac conditions such as ischemia, myocardial infarctions, arrhythmias, and other abnormalities. The lead that we'll use to monitor, non-diagnostically, but just to monitor the patient, is lead 2. So we have a rhythm strip down here, which shows lead 2. And the reason we use lead 2 is because it provides a reliable and easily obtained view of electrical activity of the heart. Lead 2 is considered to be a standard lead in ECG interpretation, which means it's often used as a reference point when comparing other leads or analyzing the overall ECG. So I do recommend, let's just say you only have one lead that you're viewing on the monitor just to monitor the patients, place it so that you're on lead 2, for example, not on lead 1 or lead 3. So the goal here is not necessarily to go into a lot of detail in terms of the electrical activity, because you're learning that in bio, but it's important to just have a quick little recap in order to understand what we're seeing on the ECG tracing based off of the electrical activity of the heart. So the electrical conduction system of the heart is a specialized network of cells that generates and distributes electrical impulses throughout the heart, causing it to contract and pump blood. The electrical conduction system begins in the SA node, so the sinoatrial node up here, which is located in the upper part of the right atrium. The SA node is known as the natural pacemaker of the heart, as it initiates electrical impulses that stimulate the heart's contraction. From the SA node, the electrical impulses spread through the atria, causing them to contract and push blood into the ventricles. 70% of that is actually passive filling, the blood going from the atria to the ventricles, and the last 30% is active, or what we call the atrial kick. So the atria kind of pushing that last 30% of blood down into the ventricles. So in terms of the electrical activity, the impulses then reach the atrioventricular node, okay, the node between the atria and the ventricles, which is located right over here. So that is the AV node. After passing through the AV node, the electrical impulses travel down the bundle of His and its branches, which are specialized fibers that extend throughout the ventricles. Now, these fibers distribute the electrical impulses to the muscle cells of the ventricles, causing them to contract and pump blood out of the heart. Okay, pumping blood out of the heart. The electrical conduction system of the heart is critical for maintaining normal heart function and rhythm. Any disruptions or abnormalities in the conduction system can lead to arrhythmias or abnormal heart rhythms, which can be potentially life-threatening. So you can imagine that if you do not have proper electrical conduction of the heart, you will not have proper mechanical contraction of the heart, and therefore you will not be able to properly distribute oxygen-rich blood to the bodies, leading to a slew of events. So various cardiac conditions such as heart disease or electrolyte imbalances can affect the electrical conduction system and cause arrhythmias. So we need to be able to pick up on those arrhythmias from reading the ECG. Just a little bit more information here, talking about the SA node, the AV node, and the left and right bundle branch blocks or bundle branches, excuse me. What are their heart rates? Okay, so the SA node being the natural pacemaker of the heart, it'll typically have a rate between 60 to 100 beats per minute. But if we're going down here to the atrioventricular junction, it'll be around 40 to 60 beats per minute. And if we're going any lower, we're going to be less than 40. So one thing you can remember is like the lower we go down, the slower the heart rate will be. So this is just something that you're going to be looking for when you're looking at the ECG. If you're looking at a rhythm that's, for example, above 100, well, you can know that the electrical impulses are starting somewhere supraventricular, okay, above the ventricles, because if you were down below into the ventricles, you'd be more in the 40 to 60, okay? If you're outside of 100, you may not be, the electrical impulse may not be being sent from the SA node. It could be somewhere else, okay? It could be a beat or a signal that begins somewhere else from another cell and not the natural pacemaker cell, okay? That's why sometimes we'll call it just supraventricular, because we don't know where it's coming from. It's not necessarily coming from the SA node. One thing that you'll also notice, not only the lower, the slower, but you'll notice that on the ECG rhythm, once we'll look at the QRS complex later on, the lower it originates, the wider it'll tend to be, okay, the QRS complex. So let's look here. What do we see in terms of the electrical conduction of the heart, and then what we actually see on the ECG rhythm? So I know you've learned these waveforms before, the P, QRS, and the T, but let's go through another quick just recap. So the P wave is the first positive deflection seen on the ECG and represents the electrical activity of the atria. Specifically represents the depolarization of the atria, which is the electrical stimulation that causes the heart muscles in the atria to contract and push blood into the ventricles. The normal P wave has a duration of 0.06 to 0.12 seconds and an amplitude of up to 2.5 millimeters in lead 2. Again, remember that was our lead that we're looking at as a baseline. Abnormal P waves can indicate conditions such as atrial enlargement or an ectopic pacemaker. So that's what I was saying, ectopic pacemaker, meaning it's not coming from the SA node, it's coming from somewhere else in the atria. And then we'll look at other reasons that we can see an abnormal P wave a little bit further on in this lecture. Now the QRS complex, QRS, is the large deflection that follows the P wave and represents the electrical activity of the ventricles. Specifically represents the depolarization of the ventricles, which is the electrical stimulation that causes the heart muscles in the ventricles to contract and then push blood out of the heart. The normal duration of the QRS complex is typically less than 0.12 seconds, and the normal amplitude is less than 25 millimeters in any lead. Abnormal QRS complexes can indicate conditions such as ventricular hypertrophy or conduction abnormalities. Now the T wave is the upward deflection that follows a QRS complex and represents the repolarization of the ventricles. Okay, so the repolarization of the ventricles. Specifically, it represents the electrical recovery of the ventricles, which is the restoration of the electrical balance in the heart muscle that allows for relaxation and preparation for the next heartbeat. The normal T wave has a duration of less than 0.25 seconds and an amplitude of up to 10 millimeters in lead 2. Abnormal T waves can indicate conditions such as myocardial ischemia or electrolyte imbalances. Of course, when we're going to look at our signs of a heart attack, when we're looking at ST elevation, okay, that's our STEMI, ST elevation myocardial infarction, well, obviously we're going to have an abnormal T wave because our ST segment will be elevated. Now let's look at the anatomical landmarks for electrode placement. So here on the diagram, we have 1, 2, 3, 4, 5, 6 chest leads. Okay, they're also known as precordial leads. These are different than the limb leads, which we're putting on the arms and legs. So these precordial leads, and I'll go in the correct order. Okay, so we're going to put V1. Okay, so they also go, there's 6 of them, right? And they go V1, V2, V3, V4, V5, and V6. So we're going to put V1 in the 4th intercostal space, okay, so the space between 2 ribs, intercostal, just to the right of the sternum. Then V2 will also be in the 4th intercostal space, but immediately to the left of the sternum. We're going to skip V3, we're going to go down to V4, because we're going to go down 1 intercostal space and we're going to go mid-clavicular, so halfway from the clavicle. So that's where we're going to put our V4 in the 5th intercostal space. Then we're going to go back and take our V3 and put it in between V2 and V4. Next, we're going to skip V5 and we're going to go put V6 in the same 5th intercostal space. And it's going to be on the same horizontal level as before, okay, in the mid-axillary line. So mid-axillary, axillary meaning like the armpit, kind of really in the midline. So these are things that we saw previously, especially when we were looking at lung auscultation to understand our landmarks. And then the V5 is going to go between V4 and V6, okay? So V1, V2 are in our 4th intercostal spaces to the right and left of the sternum. Then we're going to go with our V4 to the 5th intercostal space. We're going to put V3 between V2 and V4. Then we're going to put V6 in the mid-axillary line and V5 between V4 and V6. Now, how do we find the 4th intercostal space? So the landmark that we're going to use is called the angle of Louis, and you can see it here in the photo to the left. If we look at the sternum here in the manubrium, the angle of Louis is found right here at the, or they call it here, the sternal angle, which is the manubriosternal joint. So typically what one will do is go feel the jugular notch here, or the suprasternal notch that you can see here in the photo. And you're going to come down until you're going to feel a little indentation right here. And that little indentation is going to be right here, this sternal angle. It'll be the joint between the manubrium and the sternum. If you go immediately to the left or right, well, that will be the 2nd intercostal space, okay? A common mistake that people will make will consider, they'll go right underneath the clavicle and think that's the 1st intercostal space. Be very careful. It can really throw you off just with based on the anatomy. So it's better to go this way, start from the sternal notch, go down to the sternal ankle or the angle of Louis, move directly to the right, and that'll be your 2nd intercostal space. From there, go over the rib. Then you're going to be in your 3rd intercostal space, okay, until you feel your fingers sink in again. And then another time down, and then you'll be into your 4th intercostal space, meaning you've gone over another rib, so you feel a little bump, and then boop, your finger sinks in again. That's your 4th intercostal space. Okay, so angle of Louis to the right, and go immediately to the right of the sternum, because if you go too far, people have muscle mass, they'll have adipose tissue, they can have gynecomastia or breasts. No matter how much tissue, muscle or adipose or other that people have, typically it'll always be easy to palpate the ribs if you're directly off of the sternum, okay? So stay as medial, meaning as close to this midline as possible. Don't go too lateral. So angle of Louis, sternal notch, angle of Louis directly to the right. That's your second intercostal space. Go over the rib to your third intercostal space, over the rib again to the fourth intercostal space, and that's where you'll put your V1. Then move directly across to your left side, put your V2. Then go down another intercostal space, mid-clavicular, go put your V4. Put your V3 between your V2 and your V4. Keep following that intercostal space in your fifth intercostal space. Go to the mid axillary, put your V6, and then come between V4 and 6 to put your V5. So in terms of the standard electrode placement for the 12 lead, this is the preferred method where we'll put the right arm lead, the white lead, on the right wrist, the left arm lead, the black lead, on the left wrist. We will put the green or the ground on the right leg just above the ankle, and then the left leg, the red, just above the ankle on the left leg. Okay, so this is what we call like peripheral lead placement, or what we consider is the standard placement. They will always be indicated by RA, LA, LL, RL, but if you want to memorize, another trick is that snow, which is white, goes on top of grass, okay, which is green, and smoke, black smoke, is always above fire, red fire, okay? So white is on the right, snow over grass, and then on the left, smoke over fire. You can come more peripheral here. So you can see here they've put the white lead on the right arm and the black lead on the left arm, more around the shoulder. And then on the legs, they've kind of put it up on the quads. This is an alternative placement, but it is not our standard placement. And I'll actually show you what our contingency plan is if we can't get a good rhythm from our standard placement. So Einthoven's triangle is a diagram that represents the standard leads used in electrocardiogram. The triangle is named after a Dutch physiologist named Willem Einthoven, who was instrumental in developing the modern ECG. So the Einthoven triangle is formed by 3 points labeled as RA, right arm, LA, left arm, and LL, left leg, which represents the locations where the ECG leads are attached to the patient. The RA, LA, and LL points form the vertices of an equilateral triangle. So in the standard 12-lead ECG, 4 limb leads and 6 chest leads are used to record the electrical activity of the heart from different angles. The limb leads are attached to the RA, LA, and LL points, or of course we also have our ground, while the chest leads are attached at various points on the patient's chest, which is what we saw before. Again, those are called the precordial leads. So why it's important to know Einthoven's triangle is important because it helps to illustrate the relationship between the limb leads and the ECG. The leads on the right arm and left arm represent the potential difference between the right arm and the left arm, while the lead on the left leg is the reference point or ground. So by analyzing electrical activity recorded in these leads, we can identify various cardiac conditions, including ischemia, infarction, arrhythmias, and other abnormalities. So essentially these are vectors, okay, of potential differences. And you can see here which lead ends up being negative and positive. So in lead 1, negative is the right arm, positive is the left arm. If we're looking at lead 2, negative is right arm, positive is left leg. If we look at lead 3, negative is left arm and positive is left leg. So if you have an ECG rhythm here with a positive deflection, that means the electrical signal is being sent in the same direction, okay, from negative to positive. If you have a negative deflection, well, that means the signal is going in the opposite direction, okay? So for example, here you can see that the signal in AVR is going the opposite direction. Well, you're having a negative deflection. And actually, that's what we'll use AVR for typically. We are expecting to see a negative deflection in AVR. So to confirm lead placement, we will look at that lead. If it's negative deflection, then we most likely know that we are in the correct position. For example, if you see here though, leads 1, 2, and 3, those are all positive deflections. So here's our precordial leads. We looked at how to place the actual leads on the chest, the V1 to V6. So they're also known as the chest leads and are obviously located on the anterior chest wall, with each lead positioned at a specific location along the rib cage. So we just went through those anatomical landmarks. There's 6 precordial leads, as mentioned before, from V1 to V6, and they provide a view of the heart's electrical activity from the front of the chest. The placement of these leads allows for a better assessment of electrical activity of the left ventricle, which is responsible for pumping blood in the heart. But we can also see the right ventricle as well. We'll get many different views, okay? But it's not as good at looking at the right side of the heart. And that's why sometimes what we'll do is we'll do what's called a right-sided ECG, which is outside the scope of this class. It's actually pretty easy though. You're just going to do a mirror image of what you have here on the left side of the chest to go on the right side of the chest to have a better view of the right ventricle. So the precordial leads are unipolar leads, meaning they record the electrical activity of the heart relative to a central reference point, okay, being there. Typically, it's called the Wilson's central terminal. So unipolar leads have one positive electrode and multiple negative electrodes, and the recorded signal is the difference in the electrical potential between the positive electrode and the average of the negative electrodes. This is in contrast to the limb leads 1, 2, and 3, which are bipolar leads, meaning they record the electrical activity of the heart between 2 electrodes, and we saw before bipolar leads have one positive and one negative electrode, and the recorded signal is the difference in electrical potential between the 2 electrodes. So again, I'll say it. The recorded signal is the difference in electrical potential between the 2 electrodes. It's important to note that while precordial leads are unipolar leads, they are not equivalent to each other in terms of their placement and the specific area of the heart that they record. For example, V1 is positioned to record the electrical activity of the right ventricle, while lead V6 records the electrical activity of the lateral wall of the left ventricle. Now, understanding the placement of each precordial lead and its corresponding area of the heart is important for accurate interpretation of the ECG, because you want to know, okay, I'm seeing something abnormal in, for example, V6. Okay, well, which part of the heart is V6 looking at? Okay, so just in summary, the precordial leads provide a view of the heart's electrical activity from the front of the chest and are unipolar leads, with each lead recording the electrical activity of the heart relative to a central reference point. And understanding the placement and corresponding areas of the heart recorded by each precordial lead is crucial for accurate interpretation of the ECG. So before applying the electrodes, it'll be extremely important to prepare the skin. Okay, this won't be for all patients, but for many patients, you'll have to do some sort of skin preparation. So first, you're going to want to clean the skin. We can use our alcohol swabs to remove any oils, dirt, dead skin cells, all of which can interfere with the electrodes' contact with the skin. You'll shave the hair if necessary, just enough to be able to place the electrodes where you need to place them on the specific landmarks. Another thing that you may have to do is abrade the skin. So some of you will be equipped with this sort of fine grit sandpaper, or what's called an abrasive pad. And this, you can just rub it gently on the patient's skin where you're going to place the electrodes. For our patients who are extremely diaphoretic, which again can be very common in a patient who's having a myocardial infarction, you will have to wipe and dry the area to make sure that the electrodes stick. And you'll have actually some of our newer electrodes now have a little gel underneath it, which is very, very practical for patients who are extremely diaphoretic. Before, we only had the adhesive pad, which didn't really stick well to patients who are diaphoretic. So if you ever feel that little jelly underneath it, obviously it helps with the conduction, but it helps also keep that electrode on the patient's skin. So proper skin preparation can improve the conductivity of electrodes and can improve the quality of the ECG tracing. Because if we don't have a good quality ECG, it cannot be diagnostic, okay? You cannot interpret that ECG. So here we'll show you a couple of videos on ECG placement. This is a teacher in a school in Ontario. He has a slightly different way of landmarking or finding his landmarks. I won't lie, this is the way I used to do it too, but definitely stick with the way of the sternal notch, angle of Louis, then moving to the right. And then once you get more adept at finding these landmarks, well, then you can use this technique. But nonetheless, I just wanted to show you a video, since we're not live in class, of how to place the electrodes. So next I'll just show you how to actually then go acquire the ECG from our monitor. Here's a Zoll monitor. Of course, it's in English, but it'll still give you a good indication of which buttons to click, essentially. So he goes on to explain too, if we can send over the 12 lead ECG to the hospital. Again, it'll depend where you're working and kind of what your standard operating procedure is. But sometimes let's just say you have a patient who is actively infarcting, you see ST elevation. To activate essentially the cath lab, you will then send your 12 lead right here. You can see kind of the letter with a paper coming out 12. You would send that to the receiving hospital so that the receiving physician can confirm what you're seeing and then activate all of the steps needed in terms of a MI protocol going to the cath lab. So you can be met directly from the ER. People will come register the patient in, take blood work, and then you can go straight up to the cath lab. So next we'll look at the new electrode placement, the NEP method for obtaining 12-lead ECG. So this is a reliable alternative placement to the standard method. It's said to reduce artifact, preserve wave integrity, and maintain a high-quality interpretation. So depending on what material you read from the MSSS, there was a notice that was sent not too many months ago stating that we will directly go to the NEP method after a single failed attempt with the standard method. So again, you attempt to put the standard lead placement, you're getting a lot of artifact. So that's, you can say, is your first failed attempt, then goes directly to this new electrode placement method. Okay, so the standard technique is still the preferred method, but you can use NEP, which offers other advantages. Okay, the reason why we don't use NEP as the first or the standard approach is that it's said to be less effective in cases where there's significant abdominal movement. For example, if a patient's in severe respiratory distress, and also you'll see where the upper limb electrodes are placed, it can interfere with blood pressure measuring. When we're doing a 12 lead, if you notice in the other or the first video, the patient should be in the supine or semi-sitting position. Okay, that's where you'll get the least amount of artifact. So this is the placement for the NEP. Okay, so you can see here the electrode A, B, C, and D. Your V1 to V6, there's no change. They still stay in the same place. But where it differs is where the placement of the limb leads goes. So the arm electrodes, A and B, so right arm, left arm, are placed at the mid-arm on the lateral aspect of the biceps, immediately below the V4 horizontal line. Okay, and then the electrodes, C or D, or your right leg, left leg, become the abdominal electrodes. They're placed about 3 inches below the umbilical horizontal line, so about 3 inches below the umbilicus, on either side of the umbilical line. So let's say this is the midline, directly to the right or left. It'd almost be in line with your V1 to V2, but again, 3 inches down from the umbilicus to the right and to the left. The distance between the two should be around 4 inches. Okay, so if you've gone to do your standard approach, you're getting too much artifact, you're not getting a clear ECG rhythm, well then you're going to switch to the NEP. You're going to move this from the right wrist up to the right bicep, the left wrist up to the left bicep. Then you're going to take the two electrodes that were on your legs and you're going to put them 3 inches below the umbilicus, just to the right and left, about 4 inches apart from each other. And then you will reattempt. So what are common sources of error artifacts on the ECG tracing? Okay, they're typically caused by patient movement, either from respiratory distress, hiccups, if the patient's cold and they're shivering, if they have muscle twitches or tremors, for example, if they have some sort of disease such as Parkinson's. Okay, other things that will create artifact or electrical interference, either from cell phones, if the electrode comes in direct contact with a metal brawl wire, the interference can come from radios, and it can also come from vibrations from the vehicle, from the ambulance. It can also be from improper electrode placement. Okay, and it's really important. One of the most common causes is tension on the wires. Okay, so the wires being all twisted and having tension on it. That's why it's really important to take care of our electrode wires, really put them back into our monitors, into the monitor bags properly, effectively, and prepare them so that you're not taking them out and they're all twisted. Okay, it's always important to at least double or even triple check our electrode placement. And remember my trick that I had said initially, that you can go look at your AVR and make sure that there's a negative deflection. That could be an indication that you are placed properly. So in terms of troubleshooting, so check your electrode placement, check your lead connection. Some of them could have become detached. Check for electrical interference things such as radio, cell phones. Check to make sure that there's no tugging on the wires. Make sure that the patient is placed correctly. The patient is not cold, okay? And it's important to correct these errors or to correct the artifact to make sure that we don't have a misdiagnosis or just a lack of diagnosis because we have a non-diagnostic ECG. Okay, so this is a standard 12-lead ECG. Again, you can see here my AVR, negative deflection. All my other leads have a positive deflection. I have a nice isoelectric line. Okay, the isoelectric line is this line down here. I'm not seeing a whole bunch of artifact. Okay, would be a nice tracing that would be diagnostic. I can use this tracing to then go analyze. Here's an example of a non-diagnostic ECG. So in my, here my lead 3, it's not bad, but you can see here my lead 1 and my lead 2. I have what's called a wandering baseline. So my isoelectric line is all over the place. It's called a wandering baseline. I could not use this ECG to interpret anything. I'd have to do a second attempt. Okay, so I would troubleshoot, try to see what's going on, what's causing my wandering baseline. Is it the patient movement, breathing, excessive difficulty breathing? And then I would go and try to correct that. So here's another example of an ECG where I have a lot of artifact. You can see here, at least I'm seeing waveforms, but I'm seeing a lot of artifact right here. Here's another example where one of my leads seems clear enough, but I have artifact here, which again makes my ECG uninterpretable. So let's just look at the protocol now. The protocol right now is called Tech 11. This is for our 12-lead ECGs. We do have inclusion and exclusion criteria, so which patients can and cannot get a 12-lead ECG. Again, it's a protocol. When you will become clinicians, you will be able to make a decision on your own, but for right now, this is the protocol. If a patient is 18 years and older, and has one of the following presentations: primary, secondary complaint of persistent or resolved pain of any type, squeezing, burning, indigestion, etc., or discomfort in the region between the umbilicus and the jaw, including the back of the arms, or usual angina pain that prompted the call, bradycardia, tachycardia, or palpitations, syncope or near syncope, or if the patient is 65 and over and has one of the following presentations: primary complaint, sudden unexplained weakness or diaphoresis, sudden unexplained dyspnea. Okay, so this is our protocol. You need to memorize it. You need to understand until things change. But I want you to know that you should never withhold a 12-lead ECG from a patient that you think could be suffering from some sort of cardiac abnormality. So if you have a patient who's 16 and is known to have, something like Wolff-Parkinson-White, okay, and is known to have tachycardias, please don't withhold an ECG because they're under 18, okay? So if you have any suspicion of somebody who has any type of cardiac abnormality, perform a 12-lead ECG, but know that the protocol states the patient has to be 18 and over with one of these specific complaints, okay? The exclusion criteria: situations where the primary complaint is of traumatic origin. And even this, I don't know, it depends. We all saw that football player who went into what was called RONT phenomenon, okay? They received a blow directly to the chest and went into a lethal arrhythmia. So again, I don't necessarily 100% agree. If somebody's gotten something to the chest, I would probably do a 12-lead ECG, okay? Of course, it wouldn't be my first intervention that I would do. I would obviously rule out anything that's in my primary, okay? But if I had the time, I would go check to see, to make sure that if their chest received a blow, well, they could have affected the mechanical and electrical activity of the heart, okay? That football player, as soon as we saw the hit, I think anybody in healthcare saw, oh my goodness, it must be commotio cordis, or what we call the RONT phenomenon, which means receiving a blow directly to the heart, right in that heart's relative refractory period, which I'm sure you've covered in bio. But essentially, that's where you'd have to be extremely unlucky to get that, and that can throw the heart into an arrhythmia. So again, but exclusion criteria: situations where the primary complaint is of traumatic origin, consciousness level of P or U, respiratory failure, distress, patients resuscitated post-cardiac arrest. So you'll see too, when you take ACLS, one of the first things that you do post cardiac arrest is to do a 12-lead ECG. Okay, so these are exclusion criteria for now. Again, for the most part, I understand why they're coming up with these contraindications, exclusion criteria. I believe they don't want you to omit to do something else that's more important. But as clinicians, as you move through your education, I think you'll be able to understand when the right time is to perform the right intervention. And to do a 12-lead ECG immediately for a patient who doesn't require it, okay, well, that would be a mistake. But to not do an ECG on somebody who requires it is equally a big mistake. So some specifications: aim to obtain a 12-lead ECG within 10 minutes of arriving at the patient's side. Serial ECG acquisition, so meaning taking several ECGs during transport, should be performed under conditions appropriate for obtaining a quality ECG. Remember, in a moving vehicle, it is not appropriate to do an ECG. You're going to have a lot of artifact, and you don't want to avoid transporting to take ECGs, okay? So they say keep it to a maximum of 2 at intervals of at least 10 minutes. So typically what I'll do, ECGs on scene, ECG right before taking off, and then an ECG once we arrive at the hospital. We park the ambulance, take another ECG, okay? Those are the 3 times that I'll take an ECG. So if there's any artifacts, check the patient's position, electrode adherence, wire crossing, and possible interference. In adult females, some precordial leads will need to be placed under the left breast. So this is very important, and I'll demonstrate it in class, but you're going to use the back of your hand. Okay, it's kind of hard because you can't visually see me, but you're not going to lift the breast with the palm of your hand. You're going to use it with the back of your hand and then go place the leads on the patient's chest. It's also very important to explain what you're going to do with the patient. So for males and females, but typically what I'll say to a female is, ma'am, I'm going to get a picture of your heart. I'm going to have to put these little stickers here on your chest, and then there's some that are going to go underneath your left breast. So what I'm going to do is I'm going to lift your left breast with the back of my hand to then go place these stickers on your left, underneath your left breast, to then take a picture. Is that okay? Once I get consent, and then I'll do it. So at least they know exactly what I'm doing, so you don't just start, lifting, their breast to go put the electrodes. It has to be very clear, and also we have to respect confidential or privacy and dignity. So if you're out in public, well, maybe it's not such a good idea to do it to expose a person's chest, okay? Unless you really, really have to. You can use blankets, and then there's other tricks to have like a privacy curtain. But if not, always make sure to, expose the chest as minimal as possible, okay? Don't just leave your patient kind of bare-chested for the entirety of transport. Do it to put the electrodes on, to get your 12-lead ECG tracing, and then cover them back up again with a blanket or their shirts. It's also important to avoid counting intercostal spaces starting underneath the clavicles. Okay, so this was that other technique. Again, typically when people do it when they're first learning, they end up putting then their V1 and V2 too high. They'll miss one space, so they'll be at third intercostal space instead of the 4th intercostal space. So be careful. Really have a systematic approach to finding your landmarks. So you're allotted up to 3 attempts to get a high-quality 12-lead ECG. 2 attempts on scene and 1 attempt in the ambulance. If you can never achieve that good quality ECG, don't waste more time, just get to the hospital. If the initial ECG is normal, take 2 more readings, like I said before leaving the scene, and then upon arriving to the hospital, because sometimes you can see an evolution, okay, right live in front of you. Good quality ECG may not be obtainable in a moving vehicle. And the specific protocols that state the use of a 12-lead include your Med 1, your Med 3, Med 8, Med 8A, Med 9, Med 10, and Med 15. So I'll stop the video now, and then in the next video, we'll be talking about how to have a systematic approach, a step-by-step approach to interpreting and or reading a 12-lead ECG.